right, perfect. So in the interest of time, let's do this thing. Thank you everyone for joining us today. My name is Talia Parker and I'm the manager of program operations at NCSD. And we're really excited to be joined by some fantastic presenters today to talk about using chatbot or texting tools in contact tracing or contact investigating. So a little bit of an overview of how today's is going to go. We're going to start with Brad's presentation and then go over to Katie, and we'll do Q&A at the end. So as our presenters are presenting, if you have any questions, feel free to put them in the Q&A box. There's also a chat function. You can use that as well, but we prefer questions be put in the Q&A box. So without further ado, I'm going to introduce Brad and we'll get started. So Brad Johnson is a medical and public health student who, in the late spring of 2020, jumped in to support the San Francisco Department of Public Health and their COVID-19 case investigation and contact tracing team. With previous experience working with some of SFDPH's finest DIS folks and with health technology in general, Brad supported the San Francisco implementation of CalConnect, California's statewide case management and contact tracing platform, as well as the development of the Virtual Assistant, an automated interactive chatbot designed to support California's COVID-19 case investigation and contact tracing teams. After seeing early success with the Virtual Assistant, Brad and the team published an article with the results in the American Journal of Public Health. When not seeing patients on the wards or studying, Brad can be found lifting heavy weights or on the dance floor. Thank you so much for joining us, Brad, and I'll pass it over to you.
Thank you for that awesome introduction. Let me share my screen so folks can see. Hello, good morning, good afternoon. Thank you for that introduction. Again, my name is Brad Johnson, and with me today I have Jane and Kiana from the San Francisco Department of Public Health. We are excited to talk to you about how we in San Francisco leveraged a chatbot to reach COVID-19 cases quickly while prioritizing our phone calls for the highest risk and most vulnerable populations. Before we go any further, let's watch a video that was created to introduce this chatbot to Californians.
23393. That's right. If you get a text from 23393, it's the California COVID-19 response team with an important message from your local health department. You can trust the text and safely click the .gov link created just for you. The 23393 virtual assistant will first ask a few questions to make sure you are you, and then give you personalized information. So, if you see a message from 23393, answer the text, click the link, help stop the spread of COVID-19 in California.
So a little bit more about the chatbot. The virtual assistant is what we call it. It is an automated interactive chatbot that is integrated with CalConnect, which is California's statewide Salesforce-based case management and contact tracing platform. Upon receipt of the lab result, cases are invited to complete the chatbot survey sent through a unique link sent via text message. This survey is available both in English and in Spanish. And as the video said, it requires cases to confirm their date of birth and zip code before it can proceed. Once they've entered or authenticated into the survey, it educates individuals about their isolation period. It asks about their ability to isolate, their symptoms, spread settings, affiliation with congregate settings, as well as their demographics. It also elicits contacts, which allows us to start the process of contact notification without needing to conduct a phone interview with the case. This here is a video that I'll play that is, there's no sound, so don't expect sound for this, but you can see it's basically a demo of what the survey looks like. So you put in your zip code and your date of birth, you authenticate in, and it tells you, you've tested positive for COVID-19. Here's some self-isolation instructions. And then the first questions it asks is, are you able to safely self-isolate? I'm not gonna show this whole video here, but I believe these slides will be shared with you. So if you want to see all the nitty-gritty details, you can watch this video on your own time. When we first introduced this chatbot, one of our biggest concerns was community trust. So we worked with our city PR team to spread the word to San Franciscans. And so here are some screenshots from that coverage that basically, again, was trying to have people be ready to receive and respond and interact with this tool. Going back to the format of the or the structure and the content of the chatbot itself, here's a schematic that shows the main sections of the chatbot. So we talked about the authentication, and the first question that it asks is about the case's ability to self-isolate. From then, it collects information about the patient's symptoms and their onset date if they have symptoms. It asks about their potential spread to other places, like have they been to school or work? And based off of these answers, there's other questions are presented, such as about like healthcare or other congregate settings that they might have visited, and more information about their workplace. Then it goes on to ask, have they had any close contacts? And then it asks them to enter that contact information. And then it asks, were they knowingly exposed to someone that was COVID positive? And if so, what type of contact? And then it ends with their personal information and demographics. So this was developed and implemented across the state of California, whereas certain counties are with the understanding that each county or health department was able to choose to use it as much or as little as they needed. In San Francisco, the policies and sort of program that we developed was such that if anyone responds no to this first question about their ability to self-isolate, we would immediately call them on that same day and offer them access to isolation and quarantine resources. You'll see here it mentions our surge strategy. So when San Francisco went live with CalConnect, which this chatbot was an integral part of, it was in November of 2020. So just as that first winter surge was starting, and our plan at the time was to send the virtual assistant to all cases and contacts over the age of 18 years, and focus our limited ability to provide phone interviews only for cases in certain zip codes that were known to have the highest number of cases and the highest need for resources. You can see here that in the 2 months of the winter surge versus the previous 2 months of non-surge, there was a 412% increase in cases, while we only had a 20% increase in case investigators, or full-time equivalent of case investigators. Meanwhile, contacts also increased over 200%. We wanted to know more specifically, or we wanted to know more as we were seeing this happening, and specifically, how did our prioritization strategy allow for us to continue to conduct phone outreach to our most highly impacted groups, such as Latinx communities. That led us to an analysis, which was eventually published in the American Journal of Public Health, which compared outcomes of the non-surge period to the surge period. Again, the non-surge period was September to October of 2020, whereas surge was mid-November to mid-January. What we found was that the percent of cases that were interviewed decreased from 85% to 75%, and those interviewed in one day decreased from 77 to 51%, while the Latinx populations, which we identified as some of our most vulnerable citizens and community members, we were able to maintain a pretty high rate, interview completion rate. It was 93% before the surge and 87% during at the end of these first 2 months of surge. So we were quite proud of this number. Another thing to note is that in this non-surge period, again, we were only doing phone interviews, and we were able to elicit about 1.14 contacts per case, whereas with the surge, that dropped to 0.68 contacts per case. Here is more data or more detailed description of what we found. And I'm just going to call out some numbers here to help you digest it. I'll take a step back and explain. So again, here is the data from the non-search period, and then over here is the search period that is stratified by our 2 tiers. The first tier of people were sent the chatbot, and we attempted to contact them with a phone interview. So that was tier 1. Tier 2 are folks that received the chatbot only. Inclusion in tier 1 was residing in one of the zip codes that we identified as high risk, or being over the age of 50 or under the age of 18. So you can see, and really sort of the focus of the zip code prioritization is in San Francisco, Latinx communities congregated in certain zip codes. So we were able to use that data in our stratification. So you can see that by stratifying the lower risk tier 2 cases out of the phone interview pool, we reduced the number of cases requiring phone interviews by 31.5%. That was huge for us. Another number to call out is using this strategy, it worked in identifying Latinx folks. Almost 85% of cases of Latinx cases fell under tier 1, which was what we were trying to do. You can see here that overall, Latinx folks had a 87.5% interview completion rate, but even more specifically, those that were in our tier 1, that rose to 90.3%. Another number that we like to call out is for those that were interviewed by the chatbot only 0.27% of contacts were elicited by the chatbot. So the chatbot was not as effective at eliciting contacts as a phone interview was. Another interesting note that I would like to share is the median time from when the chatbot was sent to by the time when we received a response was 26 minutes. Very quickly that we received a response. So to summarize these results, the prioritization of phone outreach by zip code and the use of a chatbot reduced the number of cases that would have been assigned for phone interview by 31.5%. This also likely contributed to 87.5% of Latinx cases being successfully interviewed and over half interviewed within a day of test results being received. This was achieved despite the high number of cases, or despite the number of cases increasing several fold between the non-surge and surge periods. And this chatbot allowed the San Francisco Department of Public Health to instantly reach newly diagnosed cases with minimal human effort during a significant surge. Next, I'm going to invite my colleagues, Jane and Kiana, to talk about the current state and on how it's currently used. Jane, Kiana, can you unmute and speak?
Thanks, Brad. Can you hear me okay?
Yep.
Great. Yeah, so Jane and I are just going to walk through how SFDPH, how we're currently using the VA and text message features within CalConnect. One thing I wanted to point out is, I think, Brad, you were showing a slide where it showed chatbot and phone interview and just chatbot. So in the current state, we no longer do individual phone interviews, both for case investigation and contact tracing with cases or contacts. And we primarily use the VA to engage with cases and also the text message feature within CalConnect. So currently we send the virtual assistant and an INQ SMS. So those examples are on the left and right hand side to all cases and contacts aged 18 and older. And so that's an automated feature, and that's sent out throughout the day as cases and contacts are in the system. If we do have someone that responds to the VA that they can't safely isolate, those are separately managed by the COVID Resource Center, and they follow up with those cases and refer them to resources. And then separately, we do send a school-specific SMS, and that links them to school-specific INQ information, and that's sent to cases and contacts 0 to 17 years of age. And so again, that links them to information resources for their parents to access, and that's sent out several times a day, but this is not automated since we send it to a subset of our cases based on age. And the benefit of utilizing these text messages with these customized links is that we're able to track the website analytics. So for the VA, we are able to track those analytics within CalConnect, but for the text messages through CalConnect, we're able to track those through those website analytics. And Jane's going to walk us through some of the engagement that we see there.
Thanks, Kiana. I think one of the important things to point out before we dive into the analytics here is that the reason for the switch. Initially, Brad spoke to reaching out to a subset of folks in San Francisco based on priority zip codes. And that worked wonderfully during the initial phase of COVID, where flattening the curve was possible. Getting folks to isolate, getting folks to quarantine to really stop the spread. When Delta hit, and now even more so with Omicron, it's just not possible to contain as well. So it was just not possible to reach out to as many folks, or any folks for that matter, because case numbers were just so high. So our strategy shifted away from individual CICT towards more of a priority towards containing outbreaks where we could in high, like very vulnerable populations such as schools or long-term care facilities and shelters. So the VA kind of serves as the point of contact for all CICT essentially now. You know, everybody that tests positive in San Francisco gets this case survey. And that has taken the place of the calls, because again, case numbers are just too high, and it makes more sense to allocate our resources towards more vulnerable populations like school-aged kids and those in long-term care facilities. So the school-specific SMS is what you see there on the right-hand side of your screen. And it links to a web page with a lot of information specific to schools, things that parents would be interested in and hopefully find useful. And again, I think the cool part of using these custom links in the automated text messages, and the SMS for schools is not automated, but the other one is that super high value and high engagement with very little interaction from staff members. So, you know, staff resources are kept at a minimum, but the payoff is huge. And I think we can see that on the next screen, or the next slide. So here is what the analytics look like for the school's SMS. You can see the link up here. And as of today, we've sent out 2,328 individual text messages. That's actually you're not going to see that listed here. That's in a different report within CalConnect. But the cool thing about that is that I can monitor directly how many folks are visiting the website straight from the text message. So that's that first link here that says direct. It doesn't come from sf.gov. It doesn't come from another place. It comes specifically from the text message. And that second column there that we can just mouse over, Brad. Yeah, that's perfect. Those are the unique page views. So out of however many text messages we've sent to school-aged parents or parents of school-aged kids, 1,408 unique page views have resulted from those text messages with a success rate of, I think it says 67%. So a super high engagement with very, very low engagement from staff. And I saw a question come in, if it's not automated, how does it happen? So our folks that are currently doing this work have a report that they sort from that sorts by new cases by age. So anyone under the age of 17 will receive this text message. They can do it in bulk by clicking a little box and then sending the SMS all at one time. So again, this is just a really cool feature to be able to monitor what people are, and from here, I can actually, not from the slide, but from this website, I can look at where people are going, their exit page, how long they've spent on the page, and where they focus most of their time. So this is a really powerful tool to show you what people are looking at, and then you can tailor your response to the needs of the community that you're reaching out to. So CalConnect is really interesting in that, you know, we send everyone the VA except for those under 18, because can't do that. But we send everybody the VA. We send everybody an SMS with INQ resources, and then we send a specific one to school-aged parents of school-aged kids. So lots of features to take advantage of that require very little commitment and very little staff to utilize. And I think that's a really important point as we move forward. You know, still wanting to monitor COVID, but not necessarily having the staff to do so.
Thank you, Jane and Kiana. I appreciate you joining. So why are we sharing this with y'all? We think that the significance of this is that given competing demands on health departments during COVID-19 surges, programs could experiment with more automated models of offering timely isolation resources to vulnerable communities. Systematically integrating chatbot technology into disease investigation may improve timely outreach and modernize health departments in preparation for future disease outbreaks. We see a future use case of chatbots in the STD realm. For example, in San Francisco, the current burden of syphilis cases is too high for our health department to interview all cases. We see that, or we predict that the development and implementation of a chatbot could ensure syphilis treatment completion, as well as help identify or determine the need for a follow-up call to identify partners. Again, this is not developed yet, but we see that this type of technology could be used in the STD realm. Really, it's not only for tracing, because we saw that, you know, contacts weren't elicited at a high rate, but we see the big value in providing health education, linking cases to resources, and tracing any emerging pathogen. On the topic of monkeypox, you know, if a chatbot were already being sent out to people with an STI, we could very quickly add information to provide health education regarding monkeypox, since that's on a lot of folks' minds. So that's what we had to share with you today. I wanted to thank Kiana and Jane for joining, especially on last minute notice. Meg, Alejandro, Alexandra, Maivik, Lori, Todd, and everyone at the SFDPH CICT team that helped with this project. And that's what we have. Thank you.
Thank you so much, Brad, and thank you, Kiana and Jane, for jumping in as well. Very much appreciate your insight. So if folks have additional questions for those presenters, feel free to put them in the chat or the Q&A. We can get to them at the end. But I want to move on to Katie's presentation. So I'm going to introduce Katie and then send it over to her. So Katie Macomber is the Division of HIV STI Programs Director with the Michigan Department of Health and Human Services Public Health Administration. She oversees a diverse staff and leads policy and funding initiatives throughout HIV prevention, Ryan White, epidemiology and surveillance, informatics, and STI treatment and prevention. She has over 19 years of experience with the state of Michigan. She has a bachelor's degree in microbiology and a master's in public health in hospital and molecular epidemiology, both from the University of Michigan. She has special interest in informatics, integrated surveillance systems, resource allocation, and capacity building. She is a former member of the board of directors with NCSD and a current board director of NASTAD. In the last several years, she has been deployed to the COVID response, working in areas such as case investigation, performance management, case investigation quality, staffing management for case investigations, and contact tracing informatics, among others. Thank you so much, Katie, and I will pass it over to you.
Thanks, Talia. You guys can see my slides?
Yep.
Okay, great. Thank you for having me. I am in a similar situation, I think, as Brad, where I was very thrown in deep in COVID-19 informatics and then see how that can apply to my real day job in STI. So I want to present to you a couple of the best practices from Michigan that we think will be applicable going forward, along with some limitations. I'm going to talk about two specific products today, or software programs. One is something we call SMS Text Outreach, and another one is called PEG, or it's a vet software that stands for Patient Education Genius, along with talking about some limitations. I think being involved in COVID was both a curse and a blessing, I guess. In STI programs, we traditionally have not had any attention paid to our informatics, nor money, nor urgency. And so for me to be a part of meetings where Google was calling and offering their services, we really got a very immersive experience in IT and what's possible, and I really appreciate that. So the first SMS Text Outreach is an automated texting service. I'll show you a little bit later. It uses Amazon Web Service. It was built by the state of Michigan, so it's very simple and not expensive, doesn't require a vendor, and uses the department, so SOM is state of Michigan, uses our state of Michigan short code. Then we also use PEG, or Patient Education Genius. That's a vendor software. They use Twilio instead of Amazon Web Service for their texting, and also uses our department's short code. So this is the citizen outreach. And really, I know this is very, very simple, but what was happening early on when we were trying to get a hold of people on the phone is, as you guys know, people don't answer the phone anymore. People don't answer the phone for an unknown number. And so we had early on in COVID-19 a behavioral consultant who works, I don't know, some company that came in and did consulting for us to talk about ways that surveys, large surveys, get people to answer the phone. And one of them is to text them ahead of time to say, hey, a number is going to come up on your phone. You aren't going to know the number, but it's important, so please answer the phone. And so you see a couple calls there, a couple options there. These are simple texts. You type the person's phone number in. You can select who it's from. So you can either say, I'm from a local health department or from the state of Michigan, or, you can really brand a whole bunch of different options for the office. And really the point of this was to start with those pre-call outreach. So we're just telling people like, hey, we're calling you, please pick up the phone, which can be used and effective for cases or contacts. It really turned out to be quite effective. And so then what we decided to do is do post-call options, because we're giving people a tremendous amount of information on the call. Our post-call information is really a lot of what Brad showed, linkage to referrals, information on isolation and guidance on quarantine and isolation, because we're talking to people on the phone, but it's a lot of information and giving them links and then reiterating the whole conversation. And we have these in Spanish and Arabic. You see the peer-to-peer contact notification early on when people weren't giving their COVID-19 contacts. That's fine. We were realistic that was happening, but we wanted to give people the ability to send a text to their own contacts with the information on testing and quarantine. And so I'm not going to go through all these, but this is the general overview. So this is what one of them says. So you can pick a health department. In Michigan, we're decentralized, so a lot of this work is done by local health departments. And this is some of the things that you will see. Hey, I'm Katie. I'm trying to reach you from the health department. I want to talk to you about important health information. Please call me back. And it inserts your name and inserts your direct phone number. Here's the one that says that you can text to your contacts. Now, you can think about this as sending to your sexual contacts that you don't want to name. You can see this as it's applicable here for COVID-19. These are some of so, obviously we give people a lot of information. We have a very robust website. We have a hotline. We have 211 to help people with, early on it was unemployment, access to food, utilities, assistance, housing. We have a mental health webpage specifically related to COVID-19. It's a long list, so these are just screenshots, so you can't see all of them, but this is something that we could send to someone after a call to just help reiterate some of the things that we verbally talked about. Moving on to PEG, and if you have questions about any of these, we can come back to them. So PEG is kind of like what Brad was talking about. Every person that's a new COVID-19 case in Michigan every day, because again, like Brad said, we're not calling people and interviewing them anymore. Everyone gets a text. And, we didn't talk a lot about the data flow in Brad's presentation, but what PEG does is allow people to enter data into this web form, which then goes back into our disease surveillance system. So we're actually collecting case report form data that people sort of self-administer. So this is what people get at 9 a.m. So if you get COVID today, you'll get this tomorrow at 9 a.m. And this is just isolation guidance and a link to the COVID-19 case report form. We are using this right now. So there's you can send multiple texts a day. We send them a 9 a.m. one, that's the initial. At 10 a.m., we send them a message about COVID Therapeutics. And so this is a link to our COVID Therapeutics page. This really increased the use of therapeutics in Michigan and is, a U.S. Department of Health and Human Services best practice for COVID therapeutics outreach. Obviously, there's, I think we all can agree, an underutilization of COVID-19 therapeutics nationally. I don't know if anyone's aware of this, but there's a new COVID-19 survey, behavioral rapid assessment survey. I'll show you what data is being collected next on the next slide, that CDC is sponsoring. And they're looking for data, and they're looking for states to collect data for the survey. And, it's just, again, emerging data that they're trying to put together about risk factors and risk mitigation that people are willing and unwilling to do for themselves and their community. So we stuck in a new 6 p.m. text that links people to the CDC survey. This is what is being collected. So this is what we're going to get once every 2 weeks. And it matches your positive cases with negative cases. So you almost get like prevalence data. And this is a CDC in collaboration with Harvard, I think, rapid assessment of local behavioral risk factors associated with COVID-19. So when you get the text and you click on the link, this is sort of what you get in the beginning. Obviously we're giving people isolation guidance and we're giving people resources on the right. We're using tellyourcontacts.org because obviously not a lot of people are doing traditional contact tracing anymore. So you can see those, that information and those links. And then as you go further into that text, you can get to the automated case report form. So some limitations in adapting this to STI work. In general, per FTC rules, you can't text someone without their consent. Right now, we're doing that for COVID because there's a public health emergency that you can use, that you can text people with COVID-19 without their consent. That's an FTC federal thing. Our compliance office and our folks in legal doesn't necessarily think that public health emergency applies to STIs. And, so there's a risk about texting people without their consent. And I don't know, long-term, that's a very big conversation that we need to have, and probably people smarter than I at the federal level need to talk about public health texting going forward. Of course, for a public health emergency and COVID-19, a pandemic, a once in a lifetime generation pandemic, it makes a lot of sense to allow people to receive texts. But I think Brad's presentation and mine has shown that people are now expecting public health to give them information and to engage via texting, which, is traditionally not how texting has worked. And that's related to the use of our short code. So we have a COVID-19 short code in Michigan. Anything that goes out from the department, whether it's a contact tracing text or a case text or any of the things I've shown you, uses this short code. The limitation of that is that if you opt out, you actually are opted out across the spectrum. So let's say I, Katie, was a contact and I'm getting texts from the contact system to say, hey, you're a contact, you need to quarantine. Here's your, and I opt out. I am then opted out across these continuum of messages unless I am manually opted back in. And most of the time people don't know that they've been opted out across the spectrum. So if I become a case later, a year later, I won't get some of these messages because I've opted out from that short code. So you have to think about with STIs, people have more than one STI over their lifetime. We don't want them to not receive information because they've opted out from a chlamydia infection 2 years ago, and now they're not receiving syphilis information. So those, I don't have answers for these things. These are just as part of my experience of adapting this stuff to STI. These are barriers that we're bumping against. I think there's really a need for like a 201 level conversation with NCSD and CDC and other consultants about how to adapt texting technology long-term. Because like I said, I know that there is significant risks and concerns with my IT department and compliance about using any of the things that have been developed for COVID for other public health purposes without consent. Obviously, if people consent, or if they come into your STI clinic for testing and they consent on a paper form or as part of the EMR, that's all fine. But it's unlikely that we're going to obtain consent from every STI case in Michigan before they test positive. And that is all I had, Talia.
Great, thank you so much, Katie. Does anyone have any questions? I just saw a question come in. What are short codes, Katie?
Oh God, I don't know if I can answer this well, but a short code is when you receive a text on your phone and instead of looking like it's a phone number, it comes up with like a 6-digit number, and ours comes up as My COVID Help Team. So it's like a branded phone number. Is that correct? I hope someone is smarter than me that knows this.
I think a short code is like in the first video that I showed, the 23393. It's a 5-digit number that is used in, like as the sending from number. Instead of it being a typical 10-digit number, it's 23393. I guess that's 5 digits. That's what a short code is.
Yeah. Yep. So it doesn't look like a phone number, and typically I think people, and you can brand them. So like ours says, ours sometimes shows up My COVID Help Team if you have caller ID or certain types of caller ID on your phone.
Perfect. It looks like we're getting confirmation from the chat that that is correct. So thank you.
Oh, good. Sorry.
And I also saw that Brad answered some questions earlier in the chat as well. Brad, did you want to expand on any of your answers before, or are you all set on those?
Sure, I can explain it just for those who aren't reading. Teresa asked about how effective is the chatbot with STDs, specifically syphilis? My response was we have not yet developed a chatbot specifically for STDs and or syphilis. However, we think it could be very useful for this use case. We think it could be useful in providing STI health education, providing linkage to resources, as well as to help trace and or determine the need for partner services. So not yet developed for STDs, but that's why we're bringing it to y'all. We think that it could be useful. And MG Omira asked about the Spanish availability of the VA chatbot. So in San Francisco or in the state of California, the first text that gets sent out after a case is positive, it starts off in English and the last line says, in Spanish, it says respond with 2 for Spanish. And once you do that, another message is sent now fully in Spanish, saying the same text that was in the first one in Spanish. And from then on, that the links that they get bring you to a Spanish language survey. So that first time that you respond to say, hey, I want Spanish, then you're basically in a whole Spanish language flow from then on. I think does that answer your questions, y'all? Okay, good.
Thank you. And Katie, I just saw that you put something in the chat, but maybe if you wouldn't mind sharing out loud. Leo asked if you know of any states that are taking the chance in texting related to STIs, or if maybe states don't have or have a workaround somehow.
Sure. No, good question. And I don't know, although I'm interested in NCSD sponsoring a survey or anything. I think right now it's legal. I think right now we could text all of our chlamydia cases, I think, because there's this public health emergency. Our compliance has said, well, it's not really for chlamydia though, right? It's really for COVID. But long term, when that FTC emergency is taken away, is it best practice to start doing a whole bunch of texting without consent? And then if that public health emergency is taken away, then what happens? Then do we have to end it? So it's a timing thing. And it's, again, I don't have a ton of technical expertise in this area. I just know that when we brought it up, there's a lot of hesitancy in our compliance office to move forward with it because of the timing and the risks, cost risk benefit ratios,
Mm-hmm.
And obviously no one in Michigan wants to risk our short code or our use of the COVID-19 to be taken away because we've broken an FTC regulation for another communicable disease that is perceived to be less serious, I guess.
I don't know if this is sort of already expected or common knowledge for everyone on this call, but in San Francisco, we don't disclose any private health information in that text message. The text message mentions there's an important health issue that we would like to discuss with you. Please click this link, and then you have to authenticate your identity before with the COVID that we give a COVID diagnosis.
Same.
Right?
In Michigan, it's not related to privacy at all. It's not a privacy issue. It's really a contract issue with your cell phone carrier. So it's about related to receiving text that you didn't want to pay for or receive or consent. So we have lots of really great restrictions on the privacy, and I'm not worried about breaching people's security. We have a lot of good limitations for that. It's more related to the consent for texting without your permission part.
It looks like South Dakota and New Jersey might be doing some of this. Sorry, I'm just looking at the chat. Okay, I'm just going by order. So do you think this is going to be a state issue, or is this being looked into at the federal level? With staffing issues and increased STI cases, this would be very helpful if we could figure out how to do this and adapt to this legally. I think, Katie, you kind of hit on that this might need to be addressed at the federal level. Frank says many locations have been able to get approval to text a patient to initiate a discussion related to the sameness as use of letter sent. But as Brad says, the information is limited.
Yeah, and we text patients. I want to be really clear that a DIS will text a patient. So it's also related to these big short code mass texts at daily batches. I don't want to equivalent that you can't text people. Public health can text people as part of a public health investigation. It's more the use of these links, embedded short codes, the higher level technology that COVID has, and systems texting versus a person with a phone. So I don't want anyone to equivalent those. In Michigan, we'll keep texting people forever. Like a DIS will text a person to say, hey, I'm DIS Katie, I'm trying to get a hold of you. That it's really related to the short code and the systems blowing out text to a whole bunch of people, from a system, not from, Oh, good. Frank sort of agrees to me.
Thanks, Frank. We also got a comment in the Q&A box. I would think that using text for an HIV outbreak would qualify as an emergency that could bypass the FTC regulations, especially for contacts of infected persons. I think we would probably agree. I don't know if either of you have any comments on that.
Mark, for those who aren't following the chat as closely, Mark Hemmert has a really interesting comment. He says there isn't a lot of guidance or clarification from the FCC or case law, but there are exceptions carved out in federal regulations. For example, there's a healthcare exemption, which allows HIPAA covered entities to send certain healthcare messages without running afoul of the Telephone Consumer Protection Act. So that sounds like the answer to me, but I'm not the
Well,
expert.
but public health is not a HIPAA covered entity. So I actually think
Okay,
that's
so maybe not.
justification that it's,
Yeah.
but it's more complicated. I mean, I think if we were a healthcare system, then it would be okay, right? I mean, I get texts from my medical clinic and doctor all the time about appointments and stuff like that, but I think we're not public health, we're public health, we're HIPAA exempt. Public health is.
What I'm hearing is this is a much bigger conversation, definitely, but I'm glad that we're starting this for sure. And I'm wondering if anybody has any additional thoughts that they want to put in the chat or questions for any of our speakers. I know that this is complicated and can get complicated, so acknowledging that as well. Any last thoughts? If not, I am more than happy. I'm sure everybody has a very busy week and I'm more than happy to give back some time. I do want to just launch a quick poll to gather some information about what you thought about today's webinar and what we'd like to see on future NIPS quarterly calls, as well as any additional feedback you have for us. So I'm going to leave that open for a little bit. But while that is open, feel free to put any last minute questions or comments in the chat box. Oh, here comes Mark. Yep, that's the tricky part. I have a feeling this specific ask had ever come up before COVID. Haven't seen any clarification or any case law specifically making that distinction yet, but I'm going to keep digging. Thank you, Mark. I might follow up with you on that, Mark. I'll be in touch. Oh, Brad, thank you. Is that the more information on your chatbot tool? Oh, perfect. There you go.
It is, and there's also information. So Accenture is the team that developed our chatbot, as well as the CalConnect Salesforce platform in California. And I believe their contact information, if you want to explore developing a similar system, their contact information or that their point of contact is in the article. So check out the article.
Perfect. Well, with that, I'd like to lead everybody in thanking Katie and Brad, as well as Kiana and Jane for joining us on today's webinar, this quarterly NIPS call. If you would like to join the NIPS listserv, feel free to reach out to me and I can make sure that you get on our listserv. I'm going to put my email in the chat right now. Also, just a plug that if you have any technical assistance needs around technology and partner services, the UTASP team at CDC is always available and happy to help. So to reach out to Frank Strona with any TA needs. And with that, I think that's all we have today. Thank you everyone for joining. And Frank just put his email in the chat. Thank you, Frank. And we will end a little early today. Thanks everyone. And I hope you have a great rest of your Wednesday.